This was an interesting experience for me. On, let's see, Memorial Day weekend. It was a busy weekend. I did 9 craniotomies over the weekend, which I don't know that I've ever done that many in a single weekend. And then the rest of my family went up to Idaho to visit my wife's parents, and I stayed at home to finish out the call week. And I had an afternoon on Memorial Day to just go for a bike ride, which is kind of unusual. The McLeans know where this is. I was riding my bike up past the house I grew up in and just sort of reflecting a little bit. And right after I took this picture, the ER called me. And this is what they called me about. So this is a man in his mid-50s, and they said that he was having altered mental status. I looked back at his history, and he had initially gone to his primary care doctor about 4 weeks prior to coming to the emergency room with some headaches and high blood pressure. So he was appropriately treated with antihypertensives, but his significant other was continuing to report that he was acting strange. And it eventually led to him going into the emergency room because symptoms were worsening. And then they did this MRI. So does anybody see anything on the MRI scan? Anybody want to just tell me what you see? I think when you look at imaging, you don't need to be an expert. You can just sort of describe what you see. And as you look at more and more imaging, things start to make more sense as you look at it. And there's some arrows for support. We're seeing this irregular Goomba mass this is on the right side. And Dr. Lee mentioned the ventricles. They're a little dilated, probably because the mass is obstructing the spinal fluid flow. The 3 images here are the contrasted images, T1 with contrast. So the mass, part of it at least, enhances with contrast. And then this is a T2 weighted image, and we can see that there's extensive edema or swelling around the mass. Okay. Any other insights? So, you're riding your bike. They're in the ER. What would you do? What would you tell the emergency room? Or you get home and you look at the scans. I mean, I wasn't that far away from home, but how would you treat this? What would be your initial things that you would do? Send them directly to palliative care, or go home and follow up in clinic, or
become a neurosurgeon.
Oh, well, you could do that. That's not recommended. Believe me, no, it's good.
I mean, you said mention the spouse. There's difference in his cognitive behavior.
Yeah. What's the timeline? We talked a little bit about that. What are some other symptoms? It's always fair to get some more information, especially as you're unsure about a situation. Try to learn as much as you can about it.
How old's the individual?
He's in his 50s.
So the spouse definitely going to say something's different than that person.
Yeah. Yeah, that's normal for 50s, I think. But
observe things.
Yeah. Yep.
Sometimes I think we need to listen to them a little bit more.
Yes.
Obviously saying something
Yeah.
different.
And actually, he was unable to give a clear history. He was not able to really articulate all of his symptoms. And yeah, Steve?
What's the the guidelines on, would you go in and try to shrink? How they use sometimes use prednisone or something like that will go in and reduce inflammation around the tumor. Is that like the specific guidelines to do that? Is that something that you would maybe try to do first, wait a couple days, see what happens to it, and then go in? And what's the guideline on that?
Well, I thought I was asking the questions, but so that's actually a really good point, though. It's been going on for a few weeks, and there's a lot of edema. So one of the initial things that you could do is start some Decadron or steroids. I sort of refer to steroids as living on a credit card. You've got to pay for it eventually, but it can buy you some time. It can settle some symptoms down. It can actually have some dramatic improvements in something like this as far as symptoms go. It doesn't fix the underlying problem, and maybe nothing fixes the underlying problem, but the steroids can be very helpful. So that was one of the things I told the emergency room, is to go ahead and initiate relatively high dose steroids. Lindsay?
You would probably want to address if you were going to do surgery if he was on any anticoagulation.
Yeah, so I agree that this might be a case for surgery. And we would want to know if they were on anticoagulation, because we would wait on steroids to do surgery at least 2 or 3 days, depending on the anticoagulant. Yeah, AJ.
Kind of going back to the physical exam, do like cranial nerve testing.
Yeah, his that's a good doing a thorough exam is always a good thing to do. The main thing that was affected here was his speech and his alertness. He was somnolent and really was not making a lot of sense. Other cranial nerves were intact. Yeah.
You could consider onboarding an anti-epileptic.
Yes. Yeah, it's in the temporal lobe, and a seizure could really complicate his situation. Maybe there's some intracranial high pressure, and then if he has a seizure on top of that, next thing you know, he's needing to be intubated or something. So we did put him on Keppra. Scott?
Biopsy?
You could biopsy, yeah.
You're working with?
Yeah, so now we're starting to think about surgical treatment, and biopsy is a reasonable option to see what the diagnosis is and then plan additional treatment. So that's a good option.
Just out of curiosity, is he right or left-handed?
He's, well, I didn't know initially. He's ended up proving to be right-handed. That's a good question. Why would you want to know?
Just gives you an indication of where Broca's and Wernicke's area of speech centers.
Yeah, and this may not have been affecting his speech directly because it's on the right side, and more of a, he's just confused and out of it because of the shift and associated edema affecting a lot of things. But yeah, that's a good question. If we're going to take out temporal lobe, we want to be probably a little bit less aggressive if they're right hand dominant and presumably left-sided speech dominant. Tyler?
I can imagine the family as well as the patient hearing that there's a mass inside of his brain are super concerned. So I think one element obviously goes without saying, but it's having that provider to patient and family conversation about, the characteristics of this appear aggressive in nature. I think it's important to be transparent up front with the prognosis and what we're dealing with. We have to do so delicately because it can be a temperamental situation, a lot of emotions and things like that. But my thought goes to what are we telling the family and how are we approaching that?
Yeah, that's kind of why I started with that picture, this moment riding my bike past my house and thinking about being in neurosurgery for a decade and all the things, and things seem pretty good. And then for this individual and his family, in a moment, all of a sudden everything changed for them. And now they're dealing with something they did not anticipate, did not predict, and life is going to be different for them. And I want to get into a little bit on how we can all help any of our patients facing change and difficulty, potentially a terminal illness, and what we can do to help them. And I think that initiating that relationship right from the beginning with being transparent and straightforward and also empathetic and caring is something Tyler's emulated very well, and we hope we all can do as well. It's very good. Any other thoughts? So we ended up taking him to surgery, and we ended up doing it pretty late the following day. Amelia brought Lindsay and I lunch to the pond with Leif, the baby. And we had a nice moment to reflect and have some good dinner, and then we did his surgery later that night. I'm going to show you this case just because I have a surgical video. I don't have one from the bigger tumor. We did a temporal lobectomy, so we removed as much as we knew we could safely within the confines of people can do a temporal lobectomy, and there's some safe parameters to do that. So we did as much as we could safely, and really got most of the tumor out at surgery, and he's recovering. This is a patient also with a right-sided temporal lobe tumor that was smaller, and she presented after a seizure, and I just wanted to show kind of what these surgeries look like. So the patient's under anesthesia, and we've exposed, we use a navigation system so we know right where the tumor is. You could also, in some of these tumors, predict exactly where it would be based off of landmarks, but it's just helpful. And gliomas and glioblastomas, they don't, they arise from cells from the brain. So if it's a metastasis or a meningioma, the appearance of the tumor is very different than the brain. Glioma and especially and glioblastoma, the appearance of the tumor is not that different from the brain. You have to kind of know what you're looking for, and sometimes we'll use intraoperative dyes to try to distinguish, because the tumor would uptake the dye more than the rest of the brain tissue. So anyway, we get into the temporal lobe, and you can see that the tumor is a little bit more purplish, or just has a slightly discolored appearance. It also bleeds more than the surrounding white matter. So typically, if you're dealing with bleeding, you're either in an area where there's blood vessels, like a sulcus, or the peel surface, or else you're in the tumor and you want to get a little bit beyond the borders of the tumor so that you can disconnect it from its vascular supply and you no longer have bleeding. So sometimes these surgeries are relatively straightforward, depending on the size of the tumor, and they can also be extremely complicated. Both of these, again, because they were in the temporal lobe, we can work around the boundaries of the tumor relatively safely and get to a point where we've resected all of the tumor that you could see on a scan. And this is the patient. This is the patient we just showed the video of. On her postoperative MRI, there did not appear to be recurrent tumor. And the pathologist, both on the frozen section during surgery and then later, a few days later, comes back and says it's grade 4 glioblastoma. And so now you're talking to the family to describe for them what this all means for them. So now we know it's glioblastoma, and the first patient was also glioblastoma. What kind of things do you talk to the family about? What do you know about glioblastoma?
I think having a conversation of goals of care, patient given the poor prognosis and poor survival rates on glioblastoma from the get-go is very important to set expectations for risk of recurrence, and kind of let them get their timeline set up.
Yeah, it's a hard conversation, and but to your point and Tyler's point, I think being very straightforward on that we don't cure this tumor. The treatment, the life expectancy without treatment is a few months, and the life expectancy with treatment is probably about a year or more. The 5-year survival rate is less than 5%. So the majority of patients don't survive long term. So I think having a conversation around the nature of glioblastoma is important. It's not easy, but it's important. Oh, Alex, sorry, I didn't see you.
Having come across a few of these patients, it's interesting. It's not everybody, but I feel like commonly the knee-jerk response is people say, well, I'm going to beat this.
Yes.
Fight it. I'm going to
Yeah.
get over it. And it's a difficult thing to balance, not just absolutely crushing somebody and just telling them you're wrong, but also not giving them false hope and supporting that thought process of being realistic. And it's understandable too that people want to kind of pass the buck and say, well, the next expert is really going to get into it with you.
Yeah.
Be superficial with you, and when you go to see the surgeon, they will get into it with you. Or we could even say, we'll kind of give you the basic information, but when you go see oncology, they'll really get to you. But they really need to hear it from multiple sources so they start to really understand. I don't think it all takes in one go.
I'm glad you brought up the idea that patients have, that they can beat it. And I wanted to show one particular individual on social media right now who had diagnosis of glioblastoma back in November, and he's posted all kinds of videos on things he's doing, specific diets, questioning the nature of cancer itself and all of the medical research. And I had a patient in clinic last week who was kind of expressing some of the same thought process. And so along the lines of what you're saying, what do we do with patients that are thinking this way?
I think you could add to the conversation about there's a lot of unknowns.
Yeah.
There's a lot of variety of this, and each case is very different, and how you respond is going to be different. And we don't know what this is going to look like.
Yeah, I agree with that. I think that I would never want to discourage someone from seeking out treatment or ways of trying to fight it themselves or taking advice from others, especially in a situation where we don't have a great answer for them. And who knows, maybe some of these things make a big difference. I don't pretend to know all of those things. So I think it's a hard question, but I would probably err more on the side of just being supportive and happy for them that they're finding some answers.
Yeah, I'd just say basically good for you for striving to do the best that you can.
Yeah.
And trying to overcome this. But if not, prepare for the possibilities and live your best life.
Yeah. Steve?
To say I think a big aspect of this is that psychological aspect, right? That mental health help that they need going through something like this, or I'm sure a lot of us have been through a family member or something that has gone through something similar, and that physical along with the mental takes a huge toll. So as a collaborating group, making sure that they have the resources that they need from the get-go, from day one, making those phone calls to friends that they know to say, hey, I want you to see this patient, just to help prepare and help also give encouragement and helping them understand kind of what the situation is, but that they have resources available. I think sometimes with stuff like this or other things that people just don't know where to go. They don't know where to turn to. And so using our resources to help them collaborate with other people can make all the difference sometimes. Even if the outcome is the same, at least they have the resources that they feel like they need or that they didn't know that they needed to whatever end it might be.
So, at this stage where we have the diagnosis, who would be important for the patient to be connecting with? What medical recommendations would we be making?
I mean, you've talked a little bit, I mean, that if we're talking with the oncologist, that would be a specialist.
Definitely oncology.
I definitely think helping them as they go through these chronic conditions, like a nutritionist would probably be somebody that would be helpful to talk to, because there's things that they can do or to keep their strength up as they go through treatments. And a psychologist or a mental health therapist would be a really ideal person to talk to as well.
We often have, they all work with physical therapy because they're going to have some, probably some residual issues related to the tumor and the craniotomy. Sometimes they'll end up going to rehab for a little while. The patient that the big tumor that I showed at the beginning, he ended up going to rehab and made a good recovery. It took him a couple weeks to really get back to being pretty well back to normal. So definitely have him connected with the physical therapy groups and occupational therapy, rehab services, and then oncology and radiation oncology. So that's kind of what I wanted to get into. So aside from all of the things that the patients might seek out from friends, family, social media, and everything that they can do, what is sort of just the medical treatment of glioblastoma? Does anybody know? What do these patients go through? Lucky for you, I have a slide. So there's a very standard protocol for glioblastoma, and the recommendation is maximal safe resection, and so that's, we don't want to cause a neurologic deficit or a significant neurologic issue in a patient that has relatively short life expectancy, and make their remaining quality of life significantly worse. So that's one of the things that we think about in surgical care. And then we want to know exactly what the tumor is. Is it truly glioblastoma, or is it a grade 3, which would be a little bit different, or something else like a lymphoma or even an infection? And then once the diagnosis is established, the patients do a 6-week course of radiation therapy and chemotherapy. And the chemotherapy is a pill, temozolomide. It's not as hard for them as some of the types of chemotherapy that is out there as far as symptoms, but it can definitely cause some symptoms. And then they go through this, and then they do some adjuvant chemotherapy as demonstrated here, several day cycle. So patients that have glioblastoma, they're going in for the radiation treatments frequently in the early going, and it's a lot of work for family, it's a lot of time, and so something to be aware of. This is a patient that presented maybe 6 weeks ago, and he had this tumor, and he's in his 60s. What do you think about this particular tumor? Any thoughts about this one? What would you do here? This one's a little bit different location, and it's in the corpus callosum. It's crossing over to the other side. In my residency program, the founder of the residency and the neurosurgical clinic knew that he had this, got his scan, looked at it, and that was it. He went home, and that was, he knew that was going to be it for him. He didn't even treat it. But this patient has a glioblastoma that I did not think I could safely remove without causing a lot of harm, and probably without even removing, a significant portion of the tumor. So it's hard conversation to not be aggressive, but we only biopsied. We just did a needle biopsy, which can be done through a tiny little incision, and decided not to try to aggressively resect the tumor. So sometimes that's the case. Here's another case that we did recently, And this patient was in his 80s. And this is also a location that would be pretty challenging to remove the tumor without significant deficit. This is more feasible for surgery than the one I just showed you. But also, it doesn't look exactly the same as the ring-enhancing 3 glioblastomas you've now seen. And it's possible that this is actually not glioblastoma. And if it's lymphoma or another type of tumor, lymphoma would be treated very differently. Usually surgery is not even done for lymphoma. So we wanted to make sure that it wasn't something else. And so this was another example of doing a biopsy up front. And I think that on the frozen, the pathologist actually wasn't sure what it was for sure. They said it's either lymphoma or glioblastoma. And we said, well, that's what we thought too. So we'll find out hopefully this week what the answer is, and then decide what to do from there. So I think that all of us will probably encounter or have encountered patients with terminal illness, specifically glioblastoma. It affects patients of all ages. We had a video at the conference last year, or the year before, last year, a gentleman in his 20s that had glioblastoma, and a little bit about his story. There was a friend who was a radiologist in the community who just passed from glioblastoma in his cerebellum, and then they can affect patients all the way into their 90s. There was a lady somewhat recently who was a nurse for 50 years or more, and one of her early nursing experiences was being involved in an emergency craniotomy for her grandma with glioblastoma. And then at the age of 90, in great health, she presented with glioblastoma and had lived a great life. So I think it's an interesting disease in some respects, but it's also a very sobering one. And I think that we have an opportunity, all of us, to be there for the patients, to help them through things, to help the families, have some hard conversations, and help them through what could be possibly the most challenging time of their lives. So thank you for coming this morning and for all that you guys do, and very grateful, and have a great day.